Hello, everyone, and welcome. Thank you very much for joining. We will give just another minute or so for more people to filter in, and then we will go ahead and get started. All right. So it is 2 minutes past the hour, so I think we can go ahead and begin. So thank you so much to everyone for joining today. Good morning, good afternoon, or good evening from wherever you are joining from. And welcome to today's webinar, which is hosted by Hepatitis Delta Connect. My name is Beatrice Sovich, and I'm a Public Health Program Manager at the Hepatitis B Foundation and the manager of Hepatitis Delta Connect. Thank you all so much for tuning in today. Today's webinar will be focused on the epidemiology and disease burden of both hepatitis B and Delta in Sub-Saharan Africa, and it will also discuss how to increase awareness and screening for the viruses, utilizing current global guidelines to recognize individuals who are at risk for developing a hepatitis Delta infection, and how best to provide support for individuals after their diagnosis. We will have the opportunity today to hear from Dr. Ijeoma Ifeorah, who will share some of her research in this area and will underscore the need for increased hepatitis Delta awareness and testing. So we look forward to a great presentation today. Next slide, please. Thank you. So before we get started, I would just like to remind all participants that during today's webinar, all audience members are muted. We encourage you to use the chat feature to let us know who you are and where you are joining from. And if you have any technical challenges, please indicate your issue using the chat box and we will address it as soon as possible.
Hello. Hello.
Oh, sorry. Could we have the next slide, please? Thank you so much. Sorry about that. I think something dropped on my end for a moment. So just to provide a little bit of background about our Hepatitis Delta Connect program. So Hep Delta Connect is a dedicated program of the Hepatitis B Foundation, and it was first established in 2016 for the explicit purpose of raising awareness about hepatitis Delta and promoting diagnosis, screening, research, and linkage to care, as well as providing support for individuals who are living with and affected by hepatitis Delta through a variety of channels. So these include email and phone consults, social media, newsletters, blog posts, a website, fact sheets available in multiple languages, focused advocacy, and webinars such as this one. We also run hepatitis Delta focused events, and we lead hepatitis Delta public health research projects. We are hoping to continue to build and expand our programming throughout 2024, and we'll keep you posted about these developments and further opportunities to get involved. Next slide, please. Thank you so much. So today we are very excited and honored to be joined by Dr. Ijeoma Ifeorah, who is a senior lecturer at the University of Nigeria, Nsukka. Dr. Ifeorah currently works in the Department of Medical Laboratory Sciences at the University of Nigeria, and she does research in microbiology, virology, and immunology. She has previous experience in advocating for the need to more fully address hepatitis Delta in the African context. So we're very excited to hear from Dr. Ifeorah today, and we're grateful for her for joining us. We invite audience members again to put any questions that you may have in the Q&A box as they arise, and they will be addressed at the conclusion of the presentation. So without further ado, I will invite Dr. Ifeorah to begin her presentation. And I think, let me share the slides. So just give me one moment to pull them up.
I think I'll be able to do that from my end.
Oh, great. Okay, perfect.
Yeah. Thank you.
Yes, thank you so much.
Share the slide. Can you confirm if you can?
Yep, we can see them. It's just, it's not in presentation mode, but we are able to see the screen.
Yeah. Is that okay now?
Yep, perfect. Thank you so much.
Yes, thank you. So good afternoon, everyone. Good morning, depending on where you're listening from. And then thank you, Beatrice, for the invitation. I'm very happy to be here with everyone as we discuss this very topic that I'm very passionate about, really, because I've had a personal experience, with hepatitis delta or with viral hepatitis. And so it's something that is very dear to me. And so, like she already said, I'm from Nigeria, and I'm from the University of Nigeria, Nsukka. And so we'll be looking at hepatitis delta in Sub-Saharan African region. And I'm sorry you won't be able to see me because for some reason, I don't know what went wrong with my video. Yeah. And so I've got nothing to disclose. And then looking at this presentation, we'll be looking at Hep B, hepatitis background. We'll also be looking at the HBV epidemiology in Sub-Saharan Africa, and then the HDV epidemiology, the seroepidemiology, and the molecular epidemiology, as well as the screening practices at the moment. As a matter of background, hepatitis delta, as we know, is an RNA virus, that will actually just require the surface antigens of HBV to be able to infect, to be able to envelope itself and then leave the infected cell. And so what this means is that you can only get HDV infection in individuals who are already infected with hepatitis B. And so this infection can occur either as a co-infection or as a super infection. But super infection with hepatitis delta will lead to kind of a quicker progression to HCC and cirrhosis and also fulminant hepatitis. Hepatitis delta is usually called the smallest of all the known human viruses to infect, all the known viruses to infect human. But usually, we get kind of really, because we call it a smallest virus, oftentimes, I don't know why, if that's the reason why it's neglected, but then it has the capacity to cause the most severe forms of viral hepatitis. Because of the fact that hepatitis delta will require HBV for it to continue its propagation, it will be good for us to look at HBV in Sub-Saharan Africa. According to the latest estimate by WHO, we have about 254 million people who are chronically infected with HBV across the world. Now, looking at the African region, we have 65 million people who have chronic HBV. And so what this means is that we have 65 people who are at risk, 65 million people who are at risk of HDV infection in the region. Now, when we look at the distribution of HBV in Sub-Saharan Africa, we will see that most countries in Sub-Saharan Africa are hyper-endemic region for HBV, usually because of vertical and horizontal transmission in early childhood. And we know that when HBV is contracted in early childhood, the tendency for chronicity is higher. Yet in Sub-Saharan Africa, we have surveillance practice, prevention, management practices that are still suboptimal. The question is, does this have any implication for HDV infection in the region? Now, we always say that preventing HBV will put an end with HDV. That's absolutely correct. But then in Sub-Saharan Africa, these preventive measures are still suboptimal in most countries where bed dose vaccination is still not fully taken. And then the screening and surveillance practices are still very suboptimal, with some regions completely not having any access to screening. And then for the screen positives, linking them to treatment is also not suboptimal. But then let's even say a hypothetical scenario where we have 100% compliance to HBV prevention and control measures in Sub-Saharan Africa. But then there are still some very critical questions that will remain, which are, what of the individuals who are already HBV infected, who are always at risk for Delta infection? Then what about those ones who we are missing because of the suboptimal HDV surveillance in the region? And so the question is, so long as that's the conclusion is, so long as there are people who are still chronically infected with HBV, HDV, hepatitis Delta will always continue to be a conversation. Now, when we talk about HDV seroepidemiology in Africa, this is an uncharted territory in the region. However, Africa is not alone in this, what I call total neglect of HDV. Even in high-income countries, you will notice that, their surveillance for hepatitis Delta is not that robust. Then in those high-income countries, you could say that their HBV vaccination is top-notch, and so they have kind of 100% compliance to bed dose vaccination and all that. But then we have people who migrate from Africa to some of those regions. And so long as there is migration, those ones will still be at risk for hepatitis Delta circulation in their population. And now, what really is the true global estimate for hepatitis Delta? This has been a matter of debate, even amongst the scientific community. There's a lot of debate among scientists regarding what really is the true global estimate of HDV. And so Africa is not alone in the neglect or a kind of having seroepidemiology of hepatitis Delta taking the back seat in viral hepatitis research. And now these are studies that systematic review that had been published in the subject of the hepatitis Delta. The striking thing here is that for all these individual studies, none of them, there are variable results regarding what is the total number of persons infected by hepatitis Delta globally. And so this is a recent study by the Polaris Observatory Collaboration Group. In this study, because of the uncertainty in HDV estimates that has been reported in literature, so they did a kind of estimation to kind of compare what the literature has and what their extrapolated estimation have. Now, this is in 25 countries and other territories across the globe. One of the striking things in this report is that none of this country is a sub-Saharan African country. The question is it that the sub-Saharan African country, we don't have good data from the region that could make it to these estimates, to this study? Or is it that the authors completely just want to concentrate in these other countries? However, they noted the limitation that no country in sub-Saharan Africa or Pacific Island, meanwhile, these are places where you also have high burden of HBV and HDV. But then one of their conclusions is that implementing reflex testing will improve estimates for HDV. Then what is reflex testing? Is the situation where amongst individuals with chronic HBV, then you screen them for antibodies to hepatitis Delta. Amongst the screen positives, then you can now further screen for HDV RNA. Then, interestingly, these authors also noted that in this country, none of them had a population level reflex testing, instituted in their country. suggesting that Sub-Saharan Africa may not be alone in the total, well, some measure of neglect, let me not say total neglect, for hepatitis delta. Now, this is a global study, a global map showing individual level HDV prevalence distribution according to Stockdale and his group. The thing that strikes here is that in HDV in Africa, in the general population, you have an estimated prevalence of about 5.97, which is higher than the WHO estimate of 4.55%. Now, you will see that according to these reports of systematic review of HDV in Sub-Saharan Africa, it appears that the greater burden is in the West and Central Africa. But then, is that really so? Because when you look, you will see that there are really little data from other parts of Africa. And then when you come to liver disease patients, I mean, those ones with advanced liver disease, there are even more sparse data in this population for Sub-Saharan Africa. And so what does that tell us? It tells us that surveillance for HBV is greatly neglected in the region. Now, when we come to country level anti-HDV prevalence estimates from the last study that I showed, something strikes out. Here in Nigeria, Nigeria is my country, but then amongst the general population, you will see an estimated pooled HDV prevalence of 10.6. But then amongst the hepatology clinic, I mean those ones in the clinic, you have a prevalence that is almost double lesser than what you have in the general population. And the same thing you have in Togo. And then the question that comes to mind is this really the true state of things in this country? Is it that the people who are HDV positive in the general population really don't go to the hospital? You know, there are a lot of things that we may look at to try to explain this outlook. But then interesting thing is that amongst all the about 45 to 46 countries in Sub-Saharan Africa, we have data only for about 20 of them. And then in hepatology clinic, we have just for 10 countries being represented in their systematic review. And then when we even get to the population that is at a higher risk for hepatitis delta infection, there is, according to this systematic review by Mayo et al., there is completely no data from Sub-Saharan Africa, both for people who are high-risk sexual behavior and then in IVDU population. So telling us the look of things regarding hepatitis delta in Sub-Saharan Africa. Now, this is my group's study on hepatitis delta in Nigeria. This was a large-scale survey of about 1,281 HBV positive individuals that we carried out amongst the 6 geopolitical zones in Nigeria. Now, this is a map of Nigeria, and Nigeria is divided into 6 zones, where around this place is called the Northeast. This is the Northwest. This is the North Central, the Southwest, the Southeast, and the South-South. Now, HBV prevalence also in Nigeria is varied according to regions. But then what we found out in this study is that there is a wide regional variation in HDV prevalence in Nigeria, and which is also what other studies have found out, really, that in terms of you can be in the same country or even in the same region, but hepatitis delta prevalence will vary. And it is not clear what are the things driving this variation in prevalence. But then something is consistent. In this population, we noted low viremia in them. I mean, out of about 61 of them that were positive for antibodies to hepatitis delta, we were only able to quantify hepatitis delta RNA in 11 of them. But these are individuals who have never been treated for hepatitis delta. And so the question is, what are the things causing low viremia in African population. And of course, when we look at studies, oh God, hold on a minute, sorry. All right. So when we look at molecular epidemiology, we are coming to this low viremia in African population because it has been established in literature that really HDV RNA is lower in African population when you compare it to other populations. And then when we look at molecular epidemiology of hepatitis delta in Africa, the landscape gets even more obscure. And now this is a map of Africa. And these lines you see is available HDV sequences from NCBI, that's GenBank, as at yesterday. So looking at this map, one might tend to say, oh, wow, Africa is doing well. We have a lot, you know. But then really, this represents only about 18% of HDV sequences that are publicly available in NCBI site. But then another thing also is that most of the sequences, more than 81% of sequences, HDV sequences deposited in GenBank actually came from Central Africa. And so you will see Cameroon having more than 300 sequences, and then some other countries having one or even none at all. And so in terms of genotype distribution, HDV will have 8 genotypes with distinct geographic distribution. Hepatitis delta 1, then 5, 6, 7, 8 is found circulating in Africa. Actually, hepatitis delta 1 has a wide geographic circulation. But then in Africa, 70% of what we have is hepatitis delta 1. Then it's important for us to know that we have what we also call the Eurasian strain of hepatitis delta. Hepatitis delta 1, you have the African strain and the Eurasian strain, but then we still have the Eurasian strain circulating amongst them, our population. And so a lot more has to be done for us to get most of our African sequences deposited and made publicly available, because this has implication for screening, it has implication for treatment, really. Now, like I said earlier, HDV RNA positive status is actually lower in African population. This is confirmed by Stockdale et al. In their systematic review, where when they compared pooled HDV RNA positivity in the studies that made it to this systematic review across all the WHO region, they found that African region has the lowest. But then we also know that HDV RNA positive status will increase the risks for liver diagnosis. Now, these are some of the studies we have done that tries to quantify HDV RNA in the region. There are many of them, but I just decided to present just these few. This is a study, the last scale study I just presented, where we had about 14.6% viremia in that population. This is another study by my group, where we had 66.7% viremia in the mixed population of HIV and chronic HBV population. Another study in Nigeria with 16%. So what this shows is that there is kind of variation even in what is reported in the same region, in the same country. There have also been a study by Andernash in 2014 that the same test kit was used, but there's a lot of variation in that test study. So the question is it really that Africa have lower HDV RNA? Now, if this is the actual case, what is driving this? What is driving this low viremia in African population, even without treatment? These are questions that are left for the researchers in Africa to answer. Now, because we know that HDV, when infected, superinfection of HDV and HDV leads to faster progression to HCC, faster progression to cirrhosis. The question is, does HDV play any role or a significant role in HCC in Sub-Saharan Africa? Now, I take us to this study by Yon et al. In 2015, where they stated that HCC occurs earlier in Africa, particularly HBV that is associated with chronic hepatitis B. Now, the question is, we know that hepatitis delta and then hepatitis B, when there is superinfection of the two, there is faster progression. But it is not clear if delta is playing any role in this earlier on age presentation of HCC that is associated with hepatitis delta in Africa, because there are no data to suggest that we understand that it might be probably multifactorial, but then it will be easy for us to just exclude or include hepatitis delta as one of the causative reasons, or as one of the reasons why we have earlier onset for HBV induced hepatocellular carcinoma. So you see here in this table, they actually showed that HBV-induced HCC will occur 5 years earlier. They usually present 5 years earlier when you compare it to HCC of other causes, while HCV will come 6 years later when you compare it with HCC of other causes. Now, let us go to screening practice. This is a place where I like to talk about HDV screening practice in Sub-Saharan Africa. HDV is underscreened everywhere in the world, but Sub-Saharan Africa, I think it's, or in Nigeria as well, at least I'm from Nigeria, I think it's a sad story, really. This is a study that we did. This study just got accepted, I think about a few days ago. We just did a small study amongst clinicians in Nigeria. And what was the intention of the study? We wanted to look at their screening practice of clinicians in Nigeria. And so, first of all, we wanted to know if they understand that hepatitis delta will require HBV for infection. I mean, that people who have HBV infection are at risk for hepatitis delta infection. And when we inquired, you will see that about 90% of them actually had this knowledge. But then when we go to the screening experience or screening practices relating to hepatitis delta and management, reverse is the case. When the question was asked, do you conduct HDV screening in your HBV patient? A whooping 91% said no, that they have never done it before. Meanwhile, the background, these are people that have practiced for like 5 years and above, but they meet people with HBV in their clinic, but then they had never screened for HDV. And then when we asked, why do you not screen for HDV? Most of the two key things came out. There were no screening tests available in the health center. Then up to 36% of them, we are not aware of any screening test for HDV amongst other reasons. Others said it's not a routine practice in their clinic or in their health facilities. And so usually they don't do it, And then amongst even those 5% or thereabouts that say that they do screen for HDV sometimes when they get people who have HBV, they actually said it was for research purposes. It wasn't as if it was for any clinical decision or something. It was just they were doing research that has to do with HDV, and so they recruited those patients and they screened them for HDV. Now, that takes us to the screening guideline for hepatitis delta in the region. We know that the European Association for Study of Liver Disease, they have a guideline. Americans have a guideline. Asian Pacific has a guideline. But then I am not aware of any hepatitis delta guideline in Sub-Saharan Africa. Of course, this is a role for the Society for Liver Disease Association or Liver Disease in Sub-Saharan Africa. This is a society for gastroenterology and hepatology in Nigeria. They do actually have a tiny line in their recommendation where they recommended that hepatitis delta be screened in people who are HBV positive. But then in that same, just a single sentence, they also noted that these testings may not be available routinely. And indeed, this is the situation. It is recommended, but it's not available. And so the clinicians won't do anything about it. And since it is not something that is routinely done, most of them don't bother to get updated or to get their patients screened about this. But then part of the drivers of this lack of guideline or limited guideline regarding hepatitis delta screening in sub-Saharan Africa is actually fueled because there are no reliable epidemiological data to inform these guidelines. And now, so what are the challenges in the field in trying to map hepatitis in sub-Saharan Africa? Lack of research interest amongst African researchers, including the funders. I had a personal experience where I had applied for a funding to do some work in hepatitis delta. Of course, it wasn't funded. And then when I asked for my reviewer's report back, they gave me a comprehensive report. And then lined in that report, one of the reviewers said, why would you want to do hepatitis delta? Why not B? Why not C? Or even E? You know, so you will see people are not aware. And really, because there is no data to suggest that this may be a burden in the continent. But then we will need to generate this data, either to say hepatitis delta is not our problem or hepatitis delta is our problem in sub-Saharan Africa. But this lack of research interest is actually is hindering a lot, because it is only researchers that will bring out data that can inform public health response to hepatitis delta. And then we have the issue of screening. You know, in Africa, where a lot of places cannot even access HBV screening, and then you are talking about Delta virus again. So it becomes important that if we do not have a rapid diagnostic test that is specific for HDV and that is also able to map out HDV of African strain, then population level HDV work will be difficult, because some of these areas, for example, in Nigeria, this area where we had high prevalence of HDV according to our study, some of these areas are not accessible. The laboratory infrastructure in some of these areas may not support even antibody testing using ELISA, not to talk of HDV RNA. But if we have a simplified platform that is easily available, that would help for mapping HDV in sub-Saharan Africa. And then there is also issue of test kit variation. And then what compounds some of all of this is the difficulty in pulling a well-characterized HBV cohort for you to now look at hepatitis delta. You know, in most of the studies, what you see is heterogeneity. You know, there is a lot of heterogeneous population, really. You will see some of these data, you know, they will populate both individuals from the hepatology clinic, individuals from general population, all in the same study group. But we know that their risk or their hepatitis antibody estimation will vary. So if we have the ability to kind of perhaps leverage already collected samples of HBV cohorts to really map or define hepatitis delta situation in Africa, that will give us a reliable data that can now inform screening guidelines in the region. Okay, but then in the world of Professor Ijeoma, you know, we will always say the Delta blues. Yes, how do we get out of these Delta blues in sub-Saharan Africa? Now, we know that there is a lot of research interest in hepatitis delta. There is also improved treatment options, many of them already approved for use. Some of them already approved for, many of them still under clinical trials. There's a lot of improved diagnostics for hepatitis delta. But then how will African scientists improve their engagement so as to improve HDV research and clinical care in the region? This is a question that African scientists, African researchers, African clinicians will need to answer, because we owe our population that duty to really understand what is happening in our population, and then to use that to inform strategies for control and elimination. And then here I try to look at ways, really, how do we get out of these Delta blues? There are many things that comes to mind, but one of the things I know is that we need to increase awareness, even amongst healthcare providers. Because when we were trying to write up the literature for our recent study on screening practices in Sub-Saharan Africa, we tried to look for studies in Africa that have looked at hepatitis screening practices in the region. It was like an uphill task. We didn't get such. And so we need to increase awareness amongst the healthcare providers who, even though they know that hepatitis Delta is a risk factor for faster progression to HCC, yet they can't be bothered about it. There has to be improved access to diagnostics. And then we need to also raise public awareness. Most people with hepatitis B, they don't know that they also stand the risk for another infection called Delta infection. Okay, and then it's actually will be a collaborative effort between research institution, international organization, national government. There has to be a data sharing so that, so that, for example, when you design your primer for detection, usually you do that with available sequences that are publicly available, because that's what is going to inform what you would use. But then if we don't have such, if we don't have a defined population for hepatitis Delta, even doing clinical trials for hepatitis Delta becomes a problem in the region. And then the crucial of the matter, as far as I'm concerned, is how do we support people with viral hepatitis? Having a diagnosis of viral hepatitis B, it's bad enough for people. And now, when you now have to come and, open another kind of one, apart from having viral hepatitis, you have hepatitis Delta. And now when you open such, you don't know where to ask this patient or this individual to go to. And so support groups need to do more. People who are involved in creating enlightenment on viral hepatitis need to talk more about viral hepatitis Delta in the region. And then I believe that it is not all doom for us in Sub-Saharan Africa. I know that the sun will rise again in terms of hepatitis Delta research landscape, so that we can give our patient a better care. So apart from doing research, I also enjoy doing photography. And so this is a sunrise that I captured in my neighborhood. And I feel that, yes, together we can do great things in Africa. And I want to dedicate this to my loved one that I have lost to the complications of viral hepatitis. These are my references. And then thank you for your time as I wait for your questions and discussions. Thank you.
Thank you so much, Dr. Ifeorah. This is a wonderful presentation, so many rich insights, and we really, really appreciate it. I know I've certainly taken a lot away from it. I think, let's see. So we have one, David mentioned in the chat. So he is in Cross River State, Nigeria. And we can start with the question that he asks, or it's just a comment more. And he says, honestly, I have been in practice for over 12 years as a laboratory personnel in the primary healthcare area and have been at the front line of advocacy and free screening campaigns with over 3,000 people screened in my state for hepatitis B. As a hepatitis B advocate, but I haven't even seen the kits for hepatitis Delta, to say nothing of being screened himself. So Yeah, so I know you had mentioned that there's kind of spotty screening availability, and then even the tests that are available are inconsistent and might be measuring different things. And I know that's the case in many parts of the world. I know even, in the United States, if people are screened for hepatitis delta antibody, but then having completion of the hepatitis delta RNA often doesn't happen, and there's different tests that are done. So I know that this is an issue around the world. But if you could just share a little more about if you have any thoughts about how to standardize
Yeah.
the screening process or anything like
Yes,
that, that would be
yes,
great.
yes. I can understand, David, when he said that he has not even seen the kids talk more of being screened, because it was just sometime in the past, sometime last month, that someone approached me and asked me, how do I get anti-HDV antibody test kits, because he was using it for his research. But the thing is that all these things are hinged in lack of awareness. Because really, in Nigeria, for example, you go to the market to buy these things. If people are not requesting for it, people that sell it won't bring it. That's the way it is. And so you will see, for example, July is coming and it's viral hepatitis day. You will see people doing a lot of campaign on hepatitis B, on hepatitis C. People don't know anything about Delta. The question is, when you say Delta, they will tell you Delta. In Nigeria, we'll say Delta. That meaning, what do you mean by Delta? They haven't heard of it. And so if they have not heard of it, they won't go looking for it. So like I said, it's all boils down to researchers in Africa, support group in Africa, and non-governmental organization in Africa to raise the voice of patients, of people who probably are dying of hepatitis delta without knowing. The thing is that the clinicians, they are not even aware. Some of them they know about hepatitis delta, but like they said, they don't know there is any screening for it. So that means that even the patient that have this infection don't know that they have this infection. And so how do you expect that marketers won't bring it in? Even when they bring it in, they are bringing in because of their research. You probably go somewhere, you have opportunity to do that. Then you bring it in, do your research, do your publication, then you go. But it has to go beyond publication. And that's where policy comes in. That's where communicating your finding in the way that will get policymakers involved. If we don't communicate this, if we don't raise this voice, because the question is, the truth of the matter is that we really don't know if it's the problem for us in Sub-Saharan Africa. And so if we don't know if it's a problem, then how do we begin to solve it? So for me, it's all borders about creating awareness, and then the market would look. Thank you.
Yeah, absolutely. And I like what you said about having a patient-centered approach, and that there's, real people who are impacted by this disease. It's not just to remove it from the realm of research a little bit, and the importance of advocacy are so crucial. We have another question in the chat, which I will just read out. So thank you, Dr. Ijeoma, for your presentation and for your work. Looking into hepatitis delta and HIV co-infection, if you can speak to that a bit, and can the test kit used for Hep B be used for hepatitis delta at all?
Okay. So there are two questions here. Did your work look into HDV and HIV infection? Yes, that's this work we published in 2017 that looked at HIV population, people who are HIV, HBV, who infected. But really, in that work, we didn't see any difference between people who don't have HIV and then people who have HIV. We didn't see any significant difference. We had about 6% in this group, and we had about 6.2% in the other group. But then there could be reasons for this. You know that with the success of heart in HIV population, their immunity is good. you know, and so some of them also remember that they share the same, will I say the same risk factors. But because of the fact that HIV is really well controlled, you know, they are just about every normal population that you get around. That's to the extent that our study was able to find out. And then the second question regarding, can you use HBV test kits to test HDV? The answer is absolutely no, because they are two different viruses. The only thing is that, and hepatitis delta, it's just the only thing it will require from hepatitis B is just that surface antigen, and that's all. And so once it gets into the cell, once it infects, it becomes an independent virus on its own. And so even going beyond testing for HDV, you can't even treat the same treatment that you used to treat hepatitis B will not treat hepatitis delta, because they are two different viruses. I don't know if that answers your question.
Yeah, absolutely. Thank you so much. Yeah, I think it's important to understand that they are distinct and have their own particular impacts. We have another comment and question. So Dr. Ijeoma, beyond words is absolutely correct, because I have also been part of training some young laboratory professionals, and I have yet to, or when you get to viral hepatitis delta, the responses are very different due to the lack of awareness. So thank you for putting this individual back on track for hepatitis delta, for being deliberate about hepatitis delta detection. So that's very encouraging. And then we have someone who is a young researcher at the National Institute of Hepatology and Virology in Mauritania, who is working on molecular epidemiology of hepatitis B. And the real problem we face is also the difficulty of obtaining diagnostic kits for hepatitis delta. The prevalence of hepatitis B is over 18.3%. And I am open to any initiatives it takes to increase interest in this subject.
Okay.
Yeah.
Let me give her, because sometimes you have to get out of your comfort zone, really. So for me, viral hepatitis in general is not just because I'm interested in doing research. I have been affected. I have lost someone too. And so when I do viral hepatitis, I do it with a lot of passion, you know. And so you have to get out of your comfort zone. If you are a young researcher, you probably have read papers on people who have done some work in viral hepatitis. Reach out to them. Send them an email. Please, I want to do this. I want to do this. Can you support with this? And I tell you, they really do support. I give you my personal experience. You know, this is my real life experience. I was reading something on Hepatitis Delta International, and then it is also important for African researchers to increase their engagement internationally. Really, you need to engage, you know, to speak out. You know, when I read that paper, I saw it called Hepatitis Delta International Network. But then when I looked at the data distribution, there was no representation from Sub-Saharan Africa. And I sent an email to the corresponding author. Why is this Hepatitis Delta International Network? And there is no representation from Sub-Saharan Africa. Do you know our HBV burden? It didn't take an hour. That email was responded to. That email response did not take an hour because it was something important. It was something important. I had gone to a conference where I approached one of the RNA kit providers, and I told them, you know, really doing research in Africa, I understand some of these things because these are my lived experiences, you know. So, and I told them, I have this population, I want to do this, I want to do this, but I don't have a test kit. And then I don't even have money to buy. I have put up some grant application, and the reviewers told me, is hepatitis delta a problem in Sub-Saharan Africa? Why don't you look at B? Why don't you look at C? Why don't you look at E? So you will see funders are not even willing to put their money there because nobody's talking about it. And when I approached them, they gave me a kit. And so you don't say, but then there are no kits. There are kits everywhere, really. But you have to reach out to groups that are already doing something, and they will be very happy to collaborate with you, really. Thank you.
Yeah, thank you so much. And I think that can go a long way towards trying to fill some of the catch-22 with having no data, but then, you know, no support to get data. So it's a constant struggle. Wonderful. We have another question. So is treatment for hepatitis B with a single medication, and have you researched into resistance due to a failure of adherence to medication for the treatment? Or is it a combination of tablets? So I think speaking to treatment for hepatitis B.
Okay, while I have to make a disclaimer here, I'm not a clinician, but I'll give you my insights from my years of experience in the field. The question is treatment for Hep B with a single medication? And have you researched into resistance due to failure? Of course, in every viral treatment, there's always a fear for resistance. You know, that's a basic because as you're giving that drug, viruses are smart. They are also trying to evade whatever you're giving them. But then some of the newer generation of drugs actually do well. Really, some of the newer generation of drug actually do well. So there might be so many things that are not even really based on science that could cause resistance. Sometimes these patients are not faithful to their drugs. And then remember that from where in my environment or in my place, viral hepatitis is not, nobody gives you treatment for free. I have had a case where during one of our studies, one of the participants, when he got the diagnosis of viral hepatitis, and she said, why not HIV? HIV would have been better for her instead of viral hepatitis. And you could understand why she's saying that, because if she had HIV, she gets into PEPFAR program and she gets her drugs free. In fact, when she doesn't take the drug, there's a counselor that calls her. We didn't see you in clinic the other day. Why haven't you come along? But in having hepatitis B, you have to navigate the treatment yourself. You have to buy the drugs yourself, even get the diagnosis that would allow the clinician to say if you're qualified for treatment or you're not qualified. Is a long walk for the patient. And so you will also have things as common as people, they will take their drugs today, and because they don't have money, they don't go on further. And those are things that can drive resistance, apart from other virological reasons for resistance, which is inherent in all RNA viruses, although HBV is an RNA virus, but then it has the capacity to mutate, like HBV is a DNA virus, but it has the capacity to mutate like an RNA virus. I don't know if that answers your question. Thank you.
Great, thank you so much. Yeah, and I think it's very important to highlight the absolute lack of support that exists for people to, even get screened, but certainly for people who are diagnosed to manage it in the real world as well as clinically. So it's a very important point. We have just a comment in the chat. So just a suggestion, let your proposal be directed to HIV donors and integrate hepatitis delta into a component because no one is interested in hepatitis delta directly. I know, yeah.
Yeah, I'm not saying that there are funders who are interested in hepatitis delta. You have Gilead, you have so many of them who are interested. The fact that one reviewer said it was not important enough, that's just one review. So that doesn't mean that there are people who are willing to fund that. And of course, you also, a lot of this integration into HIV, it actually does take, it's more about implementation science. It takes, that's where you need the government buy-in, because HIV program, it's well streamlined. And so for you to integrate something into that HIV program, it will be at policy level. But that's a good suggestion. Thank you for that.
Yeah, absolutely. I know that there are efforts being made to combine, for example, HIV, hepatitis B, and syphilis, and to bring together different diseases. So that's a good point as well. Thank you so much for the robust participation of the audience. We really appreciate all your questions. We have another one. So thank you so much for your presentation. As a person living with chronic hepatitis B and D and cirrhosis, I'm just curious about your experience. Is there evidence of reversal of cirrhosis after treatment with something like Pegasus that you're aware of?
Well, maybe this person got me wrong. I've been affected. Being affected means that I have a family member who we lost to, there is being infected and there is being affected. I have been affected by viral hepatitis because I have lost someone there to me to viral hepatitis. Yes, usually we use PEG interferon for hepatitis delta, but then even the success rate for PEG interferon is about 40%. And then you will also risk rebound. Really, it's really not, but then that's the best that is available, really. Although, especially for us here, although in Europe now you have the bulevirtide, that is microdes, that is able to do better than PEG interferon, and then there are still other drugs that are, in the developmental stage. And all these things are linked to the fact that no data. And then even to understand the basic biology of hepatitis delta that will inform drug development, things has been done, but a lot needs to be done as well. Really.
Yeah, absolutely. Thank you so much. Yeah, I know there's a lot of hope for bulevirtide to become more available in other parts of the world outside of Europe. And I know the last meeting of the European Association for the Study of the Liver, there were many clinical trial results presented for other medications as well. So hopefully those will start to make their way. But there also needs to be more clinical research in Africa as well, as there a lot of these are not tested on the continent. So very important points. Well, I think that brings us just about to the end of the hour. So thank you so much again, Dr. Ifeorah. We really, really appreciate your time and your incredibly insightful presentation. So thank you so much for being here. And I think, Shreya, if you wouldn't mind just sharing the last slide of the presentation. So just wanted to thank our audience members so much for being here today and for joining us and for participating in the webinar. And we hope that you've found it informative and valuable to the work that you do and can apply some of the information moving forward and can help to, raise awareness of hepatitis delta in your communities. We encourage you to complete an evaluation form of the webinar after it concludes, and a recording of the webinar and slide presentation will be emailed out to all attendees. We also encourage you to sign up for our hepatitis delta newsletters. We have them for both providers and people living with hepatitis delta to be added to our mailing lists. And to receive regular updates about drug development, clinical trials, research, news, and events like this one. So we'll send out the links for those in the follow-up email. And please feel free to get in touch with us using contact information on the slide and to visit our website for more information. And if you have any questions that were not able to be answered today, you can feel free to follow up via email as well, and we will try to get them to Dr. Ifeorah as well. So, so thank you so much again. Thank you so much, Dr. Ifeorah. I hope
Thank you
you
for
enjoyed the
having me.
time. Yeah.
Yeah, thank you so much. Yeah.
Yes,
Bye,
thank you very
everyone.
much.
Yeah,
And
thank you
we'll
for
be in
having
touch
me.
again.
Yeah, bye.
All right, bye-bye. Take care, everyone.